So welcome back to part 2 in this Langford Academy session on Addison's disease. And in this session, we're going to be talking about acute management. So Billy had initially, unfortunately, not a brilliant response to therapy, and that ultimately was the reason that led to his referral and to us assessing him. So he had initially been managed with intravenous fluids. We hadn't discussed his clinical examination findings in the previous section, but he, on examination, had been very classic for Addison's disease and the electrolyte derangements that went with it. So he was clinically hypovolemic with a relatively inappropriate bradycardia. And he'd been volume resuscitated with intravenous crystalloids, and also due to the high suspicion for Addison's disease, had an ACTH stimulation test performed and then had received dexamethasone intravenously, which I think is a really, really common way to manage these patients at all levels of practice, both sort of primary care, out of hours and referral. He'd also received meropitant for his nausea and paracetamol as well in case of any sort of abdominal discomfort. He demonstrated limited clinical improvement. Unfortunately, his bloods had also demonstrated relatively limited improvement. So whilst there had been a mild improvement in his sodium level and a mild reduction in his potassium level, after 24 hours therapy, this was still at a level that really many of us would be relatively uncomfortable with. I would much rather see a more significant improvement in my potassium level after 24 hours of therapy in a patient with hypoadrenocorticism. And so for this reason, he was referred for further management. I think at this stage it's really worth touching on different steroids and how they work in the body, but also what the relative makeup of glucocorticoids versus mineralocorticoids is, because ultimately then we can begin to understand why Billy may not have responded as desired to dexamethasone therapy. So I'm going to caveat this by saying I think the overwhelming majority of acute Addisonian patients will do clinically absolutely fine and perfectly well with a combination of crystalloid resuscitation, ongoing crystalloid therapy, and dexamethasone as a treatment of choice. And indeed, this is what many clinicians will use. However, if we consider the glucocorticoid to mineralocorticoid potency of dexamethasone compared to some of the other drugs in the steroid family, we can see that it essentially has zero mineralocorticoid potency. And so that can begin to explain why we can sometimes see limited improvement in our electrolyte ranges when dogs are on dexamethasone alone in the initial therapy stages of their Addison's disease. With the fluid resuscitation, we will often see a reasonable reduction in the potassium level as we improve the potential for renal excretion. And the dexamethasone certainly is very helpful in enabling our vascular system to respond to its maximal capacity to catecholamine, so improve vascular tone. And those things can both help with renal perfusion, excretion of potassium, but we're not giving anything specifically that is mineralocorticoid active if we're using dexamethasone as therapy. There are other therapies described. Some clinicians use hydrocortisone either as an intravenous bolus or as a continuous rate infusion. And some clinicians will go straight to oral therapy if patients are clinically well. So there are multiple different options, but I think it's always worth bearing in mind that there are different options available to us and we might see slightly different responses with the different options. So to reiterate, the cornerstone of initial management of patients with Addison's disease is isotonic crystalloids. And this can be any balanced crystalloid. We tend to prefer Hartmann's or lactated Ringer's solution over saline. And the reason for this is saline is more acidifying than either of these solutions and it's not a balanced crystalloid. It is ultimately as well as being more acidifying, has a much higher sodium content than Hartmann's, and therefore what we can see sometimes is that we can see a much more rapid increase in our sodium with normal saline than we can with Hartmann's, and that can be problematic as we're going to describe in a little while. So volume resuscitation, we'll use incremental boluses to effect, and then we'll use ongoing maintenance for that patient, whatever that maintenance is. So classically, for an adult dog, that'll be 2 ml per kilo per hour, plus whatever losses we're trying to account for in vomiting or diarrhea, in polyuria, polydipsia as losses, but also if they're already dehydrated, we'll need to account that into whatever this individual dog's maintenance is as well. So fluid therapy, definitely the cornerstone of management. And then often we'll need to consider additional hyperkalemia therapy. And this can be, during initial volume resuscitation, just calcium gluconate. This can be really helpful for stabilising the cardiomyocyte membranes. And that will just buy us a short period of time during our initial fluid therapy. If despite our fluid therapy and perhaps calcium gluconate, we're really struggling with our potassium levels, we can use glucose to stimulate endogenous release. Sometimes we can also give exogenous insulin as well, but those drugs together or separately both essentially work in the same way, and that is that insulin stimulates not only the uptake of glucose into cells but also will stimulate the uptake of potassium amongst other substances into cells as well. And so that's a way of redistributing potassium in the body to try and reduce the serum levels of potassium. And so sometimes we'll need to reach for these therapies, and I think the only thing that I'm particularly mindful of is the lag effect of even neutral insulin in this setting. We will often need to fairly closely monitor these patients' glucoses for sort of 12 to 18 hours after insulin therapy. I think it's really common that they can need some level of glucose support for that period of time after giving insulin in a critically ill patient when we're using it for hyperkalemia management. So once we've started appraising our sort of clinical patient in front of us, we've given them their volume resuscitation, we've decided whether or not they require specific therapy for their hyperkalemia over and above fluid therapy, and we've started that. Then we need to think about troubleshooting this sort of hyponatremia, hyperkalemia, and how we're going to move forwards with that. And so we mentioned a couple of things when we were talking through the differential slide for hyperkalemia. Hyperkalemia. But let's think a little bit more about that now. So we've mentioned already a POCUS, so a point of care ultrasound to evaluate for any free fluid that might suggest the uroabdomen, any free fluid in either body cavity that might suggest sort of third spacing of fluid. We might want to look at the urinary tract to make sure there's no evidence of any sort of obstructive disease. If we've got an effusion, we certainly want to tap it to identify whether or not that is a uroabdomen or whether there is another fluid there. So certainly those point of care testings are really valuable. But ultimately, if we've got a high suspicion for Addison's disease, we're certainly going to want to perform an ACTH stimulation test. And we're going to want to perform that before we give any steroids at all. These patients with Addison's disease do not need steroids in the first hour to two that they're in clinic. So we've got plenty of time to stim them. We can stim them during their initial fluid resuscitation phase. We don't need to wait for them to be euvolemic before we stim them. And classically, the dose that's recommended is 5 microgram per kilogram intravenously of ACTH. I think it's worth being aware that sometimes this drug can be in short supply, and studies have been done looking at much lower doses, so a fifth of this dose, 1 microgram per kilogram of ACTH. And also studies have looked at inadvertent perivascular administration of the standard dose of ACTH and demonstrated that both of these should still result in adequate stimulation. So if you have an inadvertent error that occurs at the time of your test, then probably we can still trust those results, although ideally we would want to make sure that we're giving the full dose intravenously through a catheter that we're happy is sort of nicely in situ. There's often some discussion around why people use dexamethasone in the acute setting for patients with Addison's disease. And there's various reasons, like it's widely available, it's cheap, it is often giving that glucocorticoid replacement, even though there's no mineralocorticoids, is really useful in the emergent setting. And people talk about using it as well because ultimately dexamethasone is reported not to interfere with the lab assay for cortisol, and that is indeed correct. So if you give a patient dexamethasone and then perform your ACTH stimulation test, the laboratory is not going to inadvertently measure that dexamethasone as cortisol. So you're going to get a sort of accurate result. Whereas if you use other glucocorticoid presentations, some laboratories' methodologies will inadvertently measure those glucocorticoids as cortisol. So I think one of the reasons for the recommendation for dexamethasone in the treatment setting for the acute adrenal crisis is ultimately that it doesn't interfere with your lab testing in terms of the assays for measuring cortisol. However, any glucocorticoid is got the potential to suppress your adrenal axis. So whilst dexamethasone doesn't interfere with the cortisol assay at the lab, it can still suppress your adrenal axis and potentially, if given a long time prior to ACTH stimulation test, cause you to have a falsely suppressed result. So I would always say, do your ACTH stimulation test before administering any glucocorticoids. That's the only way to be really clear that they've not interfered at all. And also, always remember to just double check with owners at home. If you're getting a flatline result on your ACTH stimulation test, make sure they've not got any inadvertent sort of steroids, either topical or oral presentations that they've been using that might have inadvertently iatrogenically caused a flatline stimulation as well. So when we talk about acute steroid replacement, and we've mentioned this a little bit when we introduced Billy, we've got a few different options. So we've got some glucocorticoid options and we've got some mineralocorticoid options. So our glucocorticoid options, we've mentioned dexamethasone as the really commonly used therapy. Hydrocortisone also described either as an intermittent bolus therapy or as a continuous rate infusion. And then if we haven't got injectable forms in stock, then oral prednisolone or injectable prednisolone is an option as well. From a mineralocorticoid standpoint, we've got hydrocortisone, which is given intravenously, although other routes can be used. DOCP is our more typical longer term replacement therapy, so that's not classically used or recommended for the acute setting. And then fludrocortisone of very limited availability now, but that was a tablet form of mineralocorticoids that many of us will be familiar with that was available 10 to 15 years ago. But again, not typically for use in the acute setting. So really in the acute setting, we've got various options for glucocorticoids, but fairly limited options for mineralocorticoids. So consensus as to which of these is best in the acute setting is actually really quite lacking. And so the recommendation will always be use what you have available and use what you're comfortable with, because ultimately adjusting to a new protocol takes time and ultimately familiarity, and you're likely to be much safer and much more effective with a protocol you're comfortable with and your colleagues are comfortable with and can support you with, rather than using a new protocol to you. I just wanted to chat a little bit about the hydrocortisone versus dexamethasone based protocols. Personally, I like to use hydrocortisone. I feel like I can tailor my therapy more specifically to individual patients because I think there's more flex and variability in hydrocortisone dosing from the perspective of it being shorter acting and therefore being able to sort of tweak your dosing more because you typically would give it 4 times a day in a patient who is in an acute crisis. But also I really like the fact that it's got a mineralocorticoid in it, and it makes sense to me really to replace mineralocorticoids as part of the acute therapy, and I find that really valuable and helpful. So that's my preferred. It's not better. Indeed, the literature would suggest that actually it's cheaper and quicker to use a dexamethasone-based protocol, and that probably is testament to the fact there's a lot more fiddling that goes on with hydrocortisone, both in terms of monitoring blood gases, but also adjusting doses, and therefore I can't recommend hydrocortisone to you as a preferred option. I can suggest it to you as an available option, and for the reasons I've used it, that's why I prefer to use it, or the reasons I've described, that's why I prefer to use it. But certainly it is not superior to dexamethasone based on the literature. One of the aspects of the acute management of Addison's disease that it's worth mentioning is sodium flux and the impact of marked sodium flux on the body, but particularly the brain. I think many of us as clinicians focus primarily on the volume replacement for Addisonian patients alongside monitoring the potassium because we're concerned about the potential impact of potassium on the cardiomyocytes, and therefore we focus our therapy on that. However, significant sodium flux can be problematic as well. And the reason for that is due to its osmolality and ultimately the fact that water follows sodium. And so significant sodium flux has the potential to cause either cell swelling or cell dehydration on a cellular level. One of the organs that is particularly vulnerable to such change is the brain. And ultimately, if we are markedly changing our sodium concentration in our extracellular fluid, then water is either going to leave or enter surrounding cells in order to sort of equilibrate and maintain sort of equivalent osmolality. Obviously, water substantially leaving or entering a cell have significant implications for underlying cell health and can either cause significant dehydration or significant swelling, either of which can potentially terminally impair cell functions and ultimately result in cell death. The brain, therefore, is relatively special in its ability to manage these possible fluxes, and the brain cells have the potential to produce something called idiogenic osmoles, which are produced in each individual brain cell and can manage the brain's osmolality so that it is better able to match the osmolality of the surrounding fluid, to reduce the impact of water flux on the brain cells as osmolality of the extracellular fluid shifts. And so long as we're changing sodium slowly, the brain can modify its idiogenic osmoles to maintain an equivalent osmolality to our extracellular fluid. And that's exactly what we want to achieve. And this is not specific to Addisonian patients. Anytime we've got a significant sodium flux, we want to make sure that any correction of that sodium is happening at what we would consider to be a safe rate. So essentially, the sort of quoted number that is safe for sodium to change, and this is as measured in extracellular fluids, so in your serum samples, on your blood gas analyzer, sodium flux should not change by more than 0.5 millimole per litre per hour. So over a 12-hour period, we're really looking for sodium to change by no more than 6 millimole per litre. And so if we're seeing really acute changes in our sodium, so we have a sudden upswing or a sudden downswing in our sodium, we want to ideally, by the time sort of 12 hours is through, have corrected for that, so that over sort of a 12-hour window, we are not seeing an average flux of more than 0.5 millimole per litre per hour during that time. So there's windows for us to be able to sort of adjust our flux up and down, because hour to hour changes aren't a huge problem so long as they're identified and corrected. But what we want to make sure is over a 6 to 12 hour window, and certainly over a 24-hour window, any flux is corrected such that we're within this safe range. And I think sometimes, and particularly when we start mineralocorticoid replacement in these patients, we can see really massive changes in sodium flux. And so one of the other reasons I do quite like to use hydrocortisone is because I'm starting my mineralocorticoid during hospitalization, during that really intense period of monitoring the blood gas. I feel like we've got much better oversight of the adjustments to the sodium levels, rather than that happening after administration of DOCP and then that potentially happening in the home environment. So I've just got here a few screenshots just to demonstrate acceptable sodium flux and what we're really looking for. So Billy has traversed from a sodium of 122 to 133 over approximately a 22-hour window. So we've got a change of 11 millimole per litre essentially over a 22-hour window, which is at the upper limit of the change, but perfectly acceptable. And we can see even actually his sodium towards the end of that period is still below the reference range, so it can take quite a long time to safely correct sodium in these patients.